Hello, my dear friends. Welcome to the educational series of Love You Zindagi. Let's continue today with direct pulp capping.
Direct pulp capping. It is the placement of a medicament or a non-medicated material on a pulp that has been exposed in course of excavating the last portions of a deep dentinal caries or as a result of trauma. What are the indications? There is a pinpoint mechanical exposure of less than 1 mm. Exposed pulp tissue should be bright red in color. Hemorrhage should easily be controlled with the help of dried cotton pellets with minimal amount of pressure. The exposed area should have a dry, clean, uncontaminated field. Exposure duration should be within less than 24 hours. The tooth should be asymptomatic, showing no signs of pulpitis. The contraindications: spontaneous or nocturnal toothaches, excessive tooth mobility, thickening of the periodontal ligament, the radiographic evidence of focal or periradicular degeneration, uncontrollable hemorrhage at the time of exposure, or any purulent or serous exudate from the exposure. There are a few limitations of direct pulp capping in the primary teeth. According to the AAPD guidelines, what does direct pulp capping procedure does in primary tooth? It causes internal resorption. There is high cellular content in the primary teeth. There is abundant blood supply. So there is a faster inflammatory response. And there is poor localization of infection. That is why necrosis and interradicular involvement does occur when we are going in or we are trying in for direct pulp capping in primary teeth. Materials used are calcium hydroxide and zinc oxide eugenol. Calcium hydroxide, its mode of action is by coagulation necrosis at the contact surface of the pulp. When viewed histologically, the underlying tissue differentiates into odontoblasts. This results in the formation of a reparative dentine bridge. What are the advantages of calcium hydroxide? It is antibacterial in action. Rapid tubular dentine formation takes place. Formation of calcific barrier is there. Has osteogenic potential. Stimulates odontoblastic activity. What are the disadvantages of calcium hydroxide? Produces coagulation necrosis, has irritating effects, causes internal resorption in primary teeth, and lacks addition to hard tissue. Coming on to zinc oxide eugenol. Its mode of action is by the sedative effects on the exposed dentine. They are the least irritating of all the dental cements. And they are also supposed to have an anodyne or an obtundant effect on pulp in deep cavities, thus reducing pain. What are the advantages of zinc oxide eugenol? It has bacteriostatic property, its minimal pulpal responses, sedative effect, and least irritating. What are the disadvantages of zinc oxide eugenol? It produces chronic inflammation, it lacks the formation of calcific barrier, it does not adhere to the tooth structure, and it has the highest solubility in oral fluids. What is the treatment procedure? When an exposure occurs, the area should be appropriately irrigated with non-irritating solutions like normal saline, just to keep the pulp moist. Care should be taken not to push the necrotic and the infected dentine chips into the exposed pulp during the last stages of caries removal. Hemorrhage at the exposure site should be controlled easily with the help of cotton pellets. The exposure site is dried and the medicament is placed directly in contact with the pulp tissue to exert a pressure, and the reparative dentine bridge response. The tooth is first restored with an interim restoration, and observation period is again 6 to 8 weeks here. If there are no symptoms present, then the tooth is finally restored with a permanent restoration. Here again, we can appreciate this case. As you can all see, the exposure, the carious exposure is very, very near to the pulp. In the second picture, we all can appreciate that the medicament has been placed, and over there, there is an interim restoration which has been placed. The last radiograph does show that a perfect bridge has been made, and then there is no periapical radiolucency present too. The tooth is healthy and asymptomatic. Now we would like to talk about the recent materials. These are the list of the recent materials which are available for both direct and indirect pulp capping procedures. First is the MTA, then we have the corticosteroids and antibiotics, we have the interned materials, the collagen fiber, the denatured albumin, laser, bone morphogenic proteins. Mineral trioxide aggregate. It is being used as a pulp capping material in mechanically exposed pulps and for root end induction in immature roots. Mineral trioxide aggregate is prepared as a mixture of powder and water and is used in the slurry form, which gradually hardens in the oral environment. What are the indications of mineral trioxide aggregate? Carious exposures in teeth with incompletely formed roots, as a pulp capping agent, and as a root canal filling material. Here we are using it as a pulp capping agent. What are the contraindications of mineral trioxide aggregate? The primary carious pulp exposures, permanent teeth with history of spontaneous pain, radiographic evidence of pulpal or periapical pathosis, calcification of the pulp chamber or the root canals, excessive hemorrhage at the site of the exposure, and exposures with purulent or serous exudates. What are the advantages of mineral trioxide aggregate? It prevents microleakage, it is biocompatible, it promotes regeneration of the original tissues when placed in contact with dental pulp or periapical tissue, has the ability to seal the dental pulp from bacterial and chemical invasion, and it helps in the dentinal bridge formation. What are the disadvantages of mineral trioxide aggregate? It causes mild periapical inflammation. There are areas of solitary calcification communicating with the deposited secondary dentine. Pulp tissue reveals inflammatory cells and a few areas of necrosis, and the setting time of this material is about 3 to 4 hours. Coming on to the corticosteroids and the antibiotics, it was introduced by Brosh J.W. in 1966. They are effective against traumatized tooth and have an obtundant effect on the acute inflamed pulp. They are antimicrobial in nature. We will now talk about the inert materials. These inert materials have the property of bacterostatic and hemostasis. They produce less inflammation but does not provide a continuous barrier of reparative dentine on the exposed pulp. Then we will talk about the collagen fibers. The collagen fibers influence mineralization and are less irritating than calcium hydroxide. This is their one very major advantage. It forms a dentine bridge in about 8 weeks of time. Denatured albumin. This protein has calcium binding properties. When applied on the exposed pulp, the protein may become a matrix for calcification, thereby increasing the chances of biological obliteration. Laser. The acronym for laser is light amplification by stimulated emission of radiation. Meyerman introduced laser for the first time. In the pulp capping, the laser was introduced by Meritz in 1998. Good results were seen with the use of laser. And the laser we use here is Nd:YAG laser. Bone morphogenic protein. It is also called as osteogenic protein 1. Urist had discovered them in 1967. It is a bioactive capping agent. Finally, we're settled down with biodentine. It is a calcium silicate based material. Its advantages include fully biocompatibility, acts as a dentine replacement, excellent sealing properties, adequate strength, and creates fast setting bridge. A dentine bridge is formed very quickly with it. It needs wet field for the setting.
Stay tuned for more insights, and I'm always available to answer your queries. Thank you.